So I see a lot of second opinions with regards to that, both from the region around Massachusetts, but also other parts of the country. Our center in general, and I brought some information about our center. You can imagine being one of the larger hospitals in the country. We do everything there. It's a very comprehensive evaluation. We do things such as, medication treatment, diet therapies, surgical therapies if we need to get to that point. And it's a luxury because we have, experts in every single field. Genetic epilepsy experts, doctors that just focus on surgery in and of itself. So a lot of different, specialists that are present at our center. This is just some information about all that. And our contact information as well if you should ever need to get, in touch with us. And I'm not going to spend a lot of time talking just because this is really an opportunity for you to ask me as many questions as you have, and I'll do my best to answer them. And if I don't know the answers, I can point you in the right direction. But I do like to start by going through just one thing, because I think it's important for families to know exactly what doctors are thinking. When you come to us in the setting of having had a concern that your child may have had a seizure. So I kind of had this, and I actually presented this last year, but it's just one slide, but it kind of goes through the thought process, and I think, again, that's kind of important. I don't know if you guys can all see this. Can everyone kind of see this? All right, good. So again, the first question that comes up is, was the event in question actually a seizure? Because you can imagine there's actually a lot of mimics, a lot of different things that look exactly like a seizure that may not be a seizure. So you can imagine you don't want to move down the path of a question of epilepsy if the event itself is not a seizure. So the first test that we typically do, and I'm sure you guys are familiar with this, but if you're not, just tell me and I can talk more about it. As we try to figure out what type of seizure it was, we think to ourselves, well, was it a generalized seizure, meaning was the seizure abnormality coming from both sides of the brain at the same time, or was it more of a focal seizure in which the abnormality may have come from one side of the brain and then possibly quickly spread to both sides? The first test that we oftentimes do is an MRI. So we look for some brain abnormality as the reason for why a child may have had a seizure. If that's negative, we start thinking about other things like genetic causes. And I think that there's a common misconception. Parents oftentimes think that a genetic cause means that it was inherited from mom or dad. And that's actually not the case. It's actually very rare for kids to have had a genetic epilepsy that is inherited from mom or dad. And there's some, that varies a bit. If there's clearly a family history of other family members having had the specific disorder, then it is carried through. But the other thing which really kind of racks our brain is that oftentimes the cause is unknown, and that's frustrating for parents but also for doctors. But unfortunately, that's the challenge with seizure and epilepsy. And then at that point, we start thinking about things like treatment. The first thing we always try to do is treat the seizures with medication. However, when medications don't work, we think about other things like diet therapy, like the ketogenic diet. I'm not sure if any of you have experience with that. And then finally, when those things fail, that's when we start thinking about things like surgery. So again, I just showed this to you to give you a sense of what we're thinking as we're evaluating kids that come to us with a possible seizure. So like I said, I wasn't planning on doing a lot of talking, so at this point I'll sort of hand it over to all of you, and if, like I said, answer any questions I can.
How reliable is that in the diagnosis of if it's looking for a cortical dysplasia versus like a low-grade glioma?
That's a great question. I find it not to be reliable, to be honest with you. I tend to use spectroscopy in settings in which I'm worried about a metabolic cause. So sometimes kids have seizures secondary to some issue with their breaking down certain things like proteins, fats. Some kids in rare cases come to us because they have a mitochondrial disorder, and I tend to use spectroscopy more in that sort of domain. If there's clearly a cortical dysplasia and there's a question of, well, is it a low-grade glioma versus a dysplasia, it could be a little bit helpful, but frankly, for me, I use it more for the question of, could this be some underlying metabolic cause? sure if that answers your question, but that's my take on spectroscopy. Yeah.
If a patient is given Ativan, say, within 6 hours of getting an EEG, do you think that the reading of the EEG would be accurate because of the medication, or would it give all the information that it could have?
Yes, that's a great question. And the answer to that is yes. Ativan, one single dose of Ativan, or even a couple of doses of Ativan, shouldn't necessarily distort EEG with regards to us being able to know if it suggests a risk of seizure. Now, Ativan can make the background brain waves a little bit slower than you might expect, but that's all right because we don't worry that much about the background brain waves in a setting in which a child has gotten a medication. Now, the question of does the EEG, can there be some change in the EEG with a kid that's on medication? The answer is yes. There are a lot of good medications that actually suppress spikes on the EEG.
What we're asking is something a little bit different. With the light of hope, depending on the website that you can go to, you can get this information. What we're asking is how can we get the people to come and say the things that we need to say about the care of people with epilepsy. So somebody who has the authority to make the changes can make those changes.
I think that once you start getting people out there, I think that once the word starts getting out, that you start telling the stories, and especially with Facebook, they start tagging other people that they know. They see something pop up in their feed, and they go, oh, that sounds like so-and-so, and they tag them. And I think that that's one of those things that if you have I don't want to say a good story to tell, if you have a story to tell, your story is going to touch someone else at some point or another. And I think that those types of stories tend to kind of snowball into other things.
I think if you go to Congress and you tell your story, you will be able to have as much as an effect if you have more stories put together that they have a common thread.
If I go to Congress, did you say?
Yes. See, what we are asking you guys, to do is to help us out change governmental policy. You're talking about changing doctors.
No, I'm not talking about changing doctors.
Changing some of the approaches.
The information that doctors give, not the approach that a doctor makes in a care. It's different than what I'm saying.
You're talking policy and Congress and how do we increase funding for research and how do we make an impact?
Actually,
on the
there's something different. Funding for care.
Right.
Not necessarily for research. Yes, we will have the research, but we care about care. The issues that people with epilepsy face are across the pendulum. Some have more needs, some have lesser needs, but they don't get the attention that they need because people are hiding. They're hiding.
Well, one of the things that you were talking about was creating this community.
There's a lot of scared people out there that have absolutely no idea. Like we said earlier, before anybody else came, we said people don't. And I said that the thing with epilepsy is that what I think is lacking is that so much of the majority of the public, they hear epilepsy and maybe the only thing they think of is seizures. That's it. And maybe they take a medication and they don't have their seizures anymore. And as far as their knowledge for that, it ends right there, right? They don't realize the daily struggles that someone has to go through that has epilepsy and all that goes into the caregiver or the person themselves taking care of themselves, trying to be independent. And I think that that's something that definitely it needs to be more widely known.
But in many ways we're talking about two different things. One is, you're absolutely right, people need information, they can get it from one another. But the problem with that, it's very helpful to those people, but it stays within that community. And one of the things that we think needs to happen is that the system has to change so that all the problems that you encountered, the orientation the doc has in the office about just doing the seizure counts, it gets expanded to something a bit bigger. And that the system is changed so that people with difficult to control epilepsy get to see someone a lot sooner in the course of their disease and illness than they do now. Because we see all the time that people, and this is not necessarily, you can be in the hinterlands in Chicago, okay, but that are in the medical hinterlands, and they never get to a place where people understand the issues for epilepsy. And that's a systemic issue. You can talk with one another about, go see Dr. X, he really helped me, and that's a very good recommendation to make. But that's a one-on-one situation where we have 800,000 people in the U.S. with intractable epilepsy, maybe a few more. So, and most of them are never getting to see an epilepsy specialist, anybody who knows anything about epilepsy. And so one of the questions we have is taking all the issues that you're dealing with, but how do we then convert that into a change in the system? Because that's what really needs to happen. And the docs really can't do this. We're always a suspect, probably with good reason. We're always suspect when we go talking about things. But it's something that the patients have to do. And so how can you take your experiences and use those to get the system to change? And that's really kind of one of the big things, because the reality is people with epilepsy don't like to talk about it, other than on Facebook, and they just don't want to talk about it because it's got lots of baggage that's inappropriate. But so how do you then take this and say, look, and when Nico said, take your story to Congress, that's exactly the issue, sort of all the problems that patients have had with their epilepsy, and it gets lost. They talk one another, but it gets lost, and so people don't get it to where it needs to go, which is to the people who can actually change the system. And that's kind of what we really think needs to happen, is that the system needs to change. I mean, Pete Engel at UCLA has gone for years about, even though epilepsy surgery for a lot of people is the treatment of choice, that it takes sometimes 20 years from the time somebody was diagnosed, even though they're clearly having intractable, before they actually get to a place where they could have had it done 15 years before. And their lives would have been, they had 15 more years more normal life. And so those are kinds of the things that, how do we affect that kind of change so that people with difficult to control epilepsy get the care they need and have all the issues addressed that you're concerned about.
Love to be part of that. And we've done it at the state level, not with the greatest success in Illinois, because Illinois has a lot of other issues that they're dealing with, right, with budget, and unfortunately it's those who are the most vulnerable, those who don't have a voice for themselves, are the ones that get the money pulled out first and have the rug literally pulled out from underneath them and don't have anywhere else to go. And I think sometimes you need to put the face with the problem, because when it's just a problem, it's easy for them just to swat away that fly. And I think that when you start putting faces, it's a little bit more difficult for them to swat.
When the psychological component comes into it, we know that patients with epilepsy have different ways of processing their emotions than someone who does not have epilepsy. And I think it's important to understand that if the psychological factors are affecting their diet, the use of alcohol, their ability to take their medications, there are certainly aspects that not necessarily are directly related to the stress of it, but that can affect their overall well-being and health. So the answer to your question in multiple parts is yes, the psychological factor is an important factor, but it's not the whole picture.
Okay, thank you.
Yeah.
At what point at what age is it considered adult onset epilepsy? I came down with epilepsy at 18, so is that considered adult onset, or is that because he didn't want to?
It's a gray zone.
Yeah, he didn't want to. He at first he said juvenile myoclonic epilepsy, but he took that back, and now he said it's partial epilepsy with secondary generalization.
So, developing seizures at age 18 can be tricky because there are a number of syndromes that can develop earlier. You mentioned juvenile myoclonic epilepsy as one, where we have teenagers or young children as early as 12 or 13 that can, or that start developing their epilepsy much later in life, like in their 20s. I think in general, if you do have juvenile myoclonic epilepsy, it still kind of falls into that juvenile category. Developing seizures at age 18 can be considered, either pediatric or adult, depending on the seizure types and depending on what is the cause of your epilepsy. When I'm sitting down here and kind of discussing adult onset epilepsy, I'm really thinking about patients who develop epilepsy after living a seizure-free life with no neurological insults, and then at some point in their life they develop head trauma, or they have a stroke, or they have an infection that then over time increases their risk for epilepsy and then develops into an epilepsy after recurrent seizures from the same area. Yeah. So I guess the short answer to your question is, without knowing you and your medical history, it's really hard for me to say, are you an adult onset or are you not? But I mean, I think either way, the therapeutic goals have to be aimed at ensuring that your seizures are appropriately treated with the right medication for your type of seizure and epilepsy to reduce your risk of having ongoing seizures. Yeah, absolutely. I'm sure you guys have a question, or are you just listening in?
So I'm on a huge cocktail of AEDs, and I feel like it's affecting my memory significantly. I feel like I'm not as sharp as I was. It's very hard to pay attention, and the quality of life and my ability to do my work is suffering. So what would you suggest? Because I went to some neurologists want to go the surgical or device route right away, and some just want to keep tinkering with the medications.
The question is really related to the use of medications and what we call polypharmacy, or the use of multiple medications, and the side effects and how that will affect your quality of life and the treatment of your epilepsy. The International League Against Epilepsy has said that if you have taken 2 medications at a therapeutic dose and you continue to have seizures, you technically fall into a category of refractory epilepsy. Refractory meaning probably not going to achieve seizure freedom with medication alone. And that's based on data from 2 doctors, Kwan and Brody, that has been looked at and re-examined over the last 15 years. And it basically shows that once you kind of have tried and failed 2 medications, you really don't have a high probability of adding a 3rd medication and achieving any better control, or a 4th medication or achieving any better control. So we know that the most common side effects of all seizure medications, or anything that actually really works on the brain, are sedation, sleepiness, right? Thought disturbances, balance problems. The more of these, what's that? Weight gain can be a side effect of some medications, and we also know that there are a couple of anti-seizure medications that also, in and of themselves, can cause cognitive problems, like topiramate or zonisamide are both associated with cognitive issues. That's why topiramate, it came out as Topamax, and now it has the nickname on the internet, Dopamax. But the point is that any cocktail, once you get past that one medication, we know that the side effects can start adding up, and adding up very quickly. Now, in terms of the second part of your question, which is, when do you really start thinking about surgery? You mentioned some neurologists discuss surgery really early on, and some say, well, let's play with the medications a little bit and try to find the right combination. In a patient who has a known specific seizure focus, and we can say confidently all the seizures are coming from one place. And if that patient has already failed a couple of different medications or multiple medications and still continues to have seizures coming from that one place, or has such bad side effects from the medication, then considering surgery is reasonable. Now, the commitment to consider surgery, though, is a big deal. What's involved with a surgical workup? Well, generally, you're going to see an epileptologist at an academic center. They're going to probably want to bring you into an epilepsy monitoring unit where you're going to be committed to staying there for 5, 6, or 7 days and getting a video EEG with your medications reduced. The reason is they want to generate those abnormal rhythms in the brain. They want to generate a seizure or something close to it so we can see where all that abnormal activity is coming from. Then you'll probably get another MRI looking specifically at that area if that focus exists, or possibly a PET scan. And then depending on how convincing that specific area is, more monitoring may be necessary. Something called a phase 2 or intracranial monitoring, where they'll put specific electrodes in the part of the brain or that specific area of the brain where it's focused on. Now, this is a whole lot of work, but why? Because we know that in patients who have surgical resection and have a consistent focus really do better and get to have their medications reduced. So if the goal here is seizure freedom, committing yourself to that 1 or 2 years required to get the appropriate diagnosis can be worth it if you are that right patient. So it's not just jumping to surgery, it's jumping to the right surgery or considering the right surgical evaluation for every patient individually.
When we want to try to activate seizures in the epilepsy monitoring unit, we'll keep people up just a few hours. Take back their medications a little bit. That tends to trigger the seizure. So sleep hygiene is probably the most important thing. Yes.
Does the glycemic levels of glucose in blood affect that type of?
It's a good question. We don't know as much about that. These experiments and observations were related to the generalized epilepsies. A guy named Gibbs discovered that actually in the 1930s and 1940s. So I think sleep hygiene is the most important thing for these self-limited epilepsies. Trileptal, carbamazepine are drugs you try to avoid in general because they can be activating in some circumstances. So stick with things that are, if you were to treat that have like a broader spectrum of action. It's kind of counterintuitive because they're focal seizures, but yeah. Yes.
For the juvenile myoclonic, do you know the #1 trigger? I can't figure out if it's diet or sleep or stress or if it's all of those things.
It could be all those things, and it will vary between people. But common things would be sleep, sometimes stress, probably to a lesser extent diet, but a contributor. And then when people are older with those is alcohol. Alcohol is a very not while you're drinking, but when your system is withdrawing from it, will be like a potent time. So those are the things we really, when you think about kids going off to college and so forth. Yeah.
My daughter does #4. We've done the full exome sequencing. It comes back negative. She's on Keppra, Topamax, Benzel. She's on CBD and the ketogenic diet, and she still has like 5 to 10 seizures a day. So we're obviously patients at Dr. Lawless's, and where he's in the process of trying to figure it out, and we're running out of hope, to figure out to control these seizures.
They're always tougher situations, when we're in this category, and particularly if we don't have a target. But
no, she's not on the full ratio yet. She's on 3-to-1.
All right.
We're building up to it.
Probably a 4, even how old is she?
2.
Oh yeah. So a 4, sometimes even a 4.25.
Okay.
We need to go to. What we want to see is at full levels of ketosis, what that does. So like in the 80 to 120 range, medium to high levels of ketosis is what we want. Yeah, in this category, so there's two things. One is don't give up hope, because we've been in this situation countless numbers of times. Like if I think back in the 30 years of working in there's always been like every moment there's like a group of children I've been worried about, and then a year goes by, 6 months go by, whatever, and I think back and I think like, oh, I'm not worried about so-and-so any longer. So, the statistics when you look going forward is, people always say, if you don't respond to 2 well-chosen drugs, the chance that the third will work is 10%. But, as Ann Berg has said, if you keep playing that out, the majority of people find something. So, it's a matter of doing logical things. But 2 things I'm glad to hear that you're saying. One is you're on the diet, because by the time you get to 4 meds, it's too much. Like you've gotta get that medication burden down, and the diet can help. So the diet can, build up that reserve enough that it can help you to kind of clean up the regimen, and then you stand a much better chance of getting on top of things. Because the problem with multiple drugs is obviously if you're on multiple drugs, they're not working well. When you're on multiple drugs, it sedates the child. And when you're sedated is when seizures love to come out. So it's like a paradoxical reaction. If you're on too much medicine, you'll be chronically sedated, and that's when seizures are much more prone to come out. So our job is to use something like the diet that doesn't sedate you. It increases the brain energy levels. So get the diet working so the brain energy levels are higher, and then whittle away at the drugs is usually a good strategy. Yeah.
We were on the CBD oil for a few months now. We just got a different, more stronger version of it, so we're hoping that works. Before the ketogenic diet, she used to have 10 to 30 a day. Now she's below 10. So something's working, we just don't know what.
What's her level of ketosis now?
It's between 80 and 120. We check. We have the ketone strips, and we check it every day. So.
Yeah, typically infants, I put in up to the 2 category, often need like ratios that get closer to 4 to 1 to really get the full benefit. And then consistently high ketosis is usually like what we need to really see how well it's working. How long has she been on it then?
Yeah, about 6 months.
6 months.
Okay.
Yeah.
Pretty good. Might have a little bit more opportunity to work with it.
Yeah.
I don't know if it's so much of a question.
Yes.
But she's my daughter. She's had seizures since 2009. We started with partial complex epilepsy. A year into it, it turned into tonic. It was the full body ones. Then we got something that everyone was telling me it's a tic, it's not seizures. We finally had a doctor diagnose us as a seizure, but it's the ones that you described that would go away by the time 16. She's going to turn 19. And it's gagging, the spitting, excessive saliva. That's all she has now. She hasn't had the convulsive ones, but these happen probably every week. We've been on so much medication, and we're at that point where we're losing hope. I don't know.
And then, when is gagging a big part of the seizure?
I have a video that I took this morning. If I could show you maybe a small portion of it.
Sure. Oh yeah.
And someone told me it was a tic, it's not seizures, it's acid reflux, it's endless things they told me.
Have you had a video EEG during it to capture one?
We have, and they said that it was minimal frontal lobe spikes. Every EEG she's had has been normal. And the epileptic spikes are minimal. Everything comes back normal. The EEGs, the MRIs. I was actually looking for you because we're out of Chicago, and you had moved a year before I got to your name.
Where do you guys live now?
In Romeoville. So we came all the way out here. When I saw your name on, I'm like, I need to talk to him.
Oh. One of the things sometimes to do, like if the EEGs have been like so-so with that kind of seizure, is maybe look into it with a MEG study.
Meg?
MEG. So seizures that are coming from a region called the insula can look like that, and they won't show up all that well on scalp, and neither will the spikes. But there's a study called the MEG, and it's a magnetic study that does the same thing as an EEG but with magnetic waves.
Okay.
Yeah, and that might be very helpful. So there's should be a scanner still up and running in Chicago.
At Lurie's Children?
May not be at Lurie yet. University of Chicago is running one, and Loyola had a scanner, still running a MEG scanner, but there's definitely one in Milwaukee. Yeah. So maybe try that.
Okay, my other problem is that she's not pregnant. So I get really concerned about medication. Is it going to affect the baby? Could it...
MEG study won't be any impact on the baby. Yeah, you can do it. And it's just like a 30-minute to an hour study. It's not dangerous.
Would the keto diet work at all for these type of seizures?
Maybe not.
No.
If it's coming from the insulin, first thing would be trying to figure out where it is and see if there's any evidence for that. But that kind of manifestation might be that particular region. It's an area that's a little bit deep to the temporal lobe, so it doesn't show up on EEG.
Okay.
So, I have treated autoimmune epilepsy with steroids. I started off by saying we have 3 epileptologists, a 4th one coming in the beginning of 2018. The one that's coming in 2018 does treat epilepsy with IVIG and immunomodulators that aren't just known autoimmune epilepsies. So he's bringing that to our practice. I only use IVIG and immunomodulators for known autoimmune epilepsy. So we will be adding that to our practice, but through him.
What would be a reason for, like, so our kiddo has the genetic epilepsy, and then all of a sudden had epileptic encephalopathy, and they hit him with high-dose steroids for 2 weeks, and 2 weeks, 15 days, and we're still tapering off because, and it, like, worked.
Stopped it.
Like, he went 48 hours without a seizure for the first time since we learned that he had seizures.
And I don't know how they're using the term epileptic encephalopathy. That's the other problem. I have hundreds of people with epileptic encephalopathy. All that means is somebody with bad epilepsy who's also severely developmentally delayed with a bad epilepsy condition. So, like, my children with, Dravet syndrome have bad genetic epilepsy who are severely delayed. They can be termed epileptic encephalopathy.
So our son has the KCTD7 gene mutation, and we were treating him with copious amounts of drugs. And then all of a sudden he had like this pretty swift neurologic decline that our closest hospital was like, oh, it's part of his condition, put him on hospice care, sent him home. UCSF was like, no, just bring him down because we are followed by them. Took him up to the machine. He was having near continuous frontal lobe spikes, and they which was different from his previous EEGs. And so they were like, no, this is epileptic encephalopathy.
So they're calling it more like an ESES, continuous spike and slow wave sleep. Okay, something more like that. Okay, I got that. I get you now. I don't have the best answer for you, but later this afternoon, I think Dr. Matt Lawless, is giving a talk on ESES and immunotherapy, or immunomodulation. I'm not exactly sure of the title, but he might be a good person to listen to. He might have more information on it. like I said, I wanted to kind of build an outline for future talks. That might be a good talk for you to go to as far as a direction. He might be able to provide more insight. So I know that people do use steroids for that. They do use stuff like high-dose Valium for that type of condition, high-dose benzodiazepines.
It's on feed.
Yeah, so it used to be Valium, and now it's probably more likely people are using high-dose Onfi and stuff like that. Some people use high-dose Depakote, but he might be a good talk to go to for more information. But in that case, I understand where they were using the term epileptic encephalopathy. A little different than how I first interpreted the question. So I understand.
I know, trying to Google it.
Yeah, so there's kind of epileptic encephalopathy as a static condition.
Yeah.
Kind of you're at a baseline epileptic encephalopathy. You were talking about an acute.
Yeah.
Okay, got it. Yeah, so I think it's Matt Lawless who's giving that talk. I think in the last hour, if you're still here. But yeah.
Thank you.
All right.
After the first one, he was sleeping with them like a lot of kids do. They were terrified. Took medication every day. And then December 12th, 2009, his parents found him, bottom bunk. He'd passed away while he was sleeping after a seizure. So when Danny died, the term SUDEP was totally foreign to his mom and dad. They had never heard of that risk before, and they learned about it from their medical examiner. So now our goal as a foundation is to obviously raise collective awareness around epilepsy, but also the risks that come with it, and specifically the risk of SUDEP. So Danny drives us to do that. So what we created, what his parents created, is the Danny Did Foundation. And the name of the foundation comes from the last line of his obituary, which my brother wrote, and that read, "Please go and enjoy your life, Danny did." And the idea is, to embrace each day and to kind of mirror his joy for life and take a tragic situation and try to make something good out of it, which is difficult, but it's kind of our way to honor him. So that's what we're doing. So kind of the primary focus for us is to advocate for open and honest dialogue between doctors and parents, or doctors and adult patients, to share all the risks that come with epilepsy. So the risk around bathing, swimming, driving if a child is old enough, the risks of head trauma, things that a lot of us have heard about from doctors, but also to talk about the risk for SUDEP. And it's not to say that we're asking them to isolate it or to call it, to call it into its own conversation necessarily, but to not leave it out of the conversation. Because when that happens, there's a blind spot, and we can't do anything as parents to try to minimize the risk because we don't know about it. So that's what we advocate for, to kind of couch it within that risk for all the risks that come with epilepsy. So SUDEP is the most common cause of death for people with epilepsy, per the National Institutes of Health. So it's a considerable risk, and obviously the fact that there's fatality, there's really no more risk serious than that for people who are either dealing with epilepsy themselves or have kids with epilepsy. So we make an analogy, when a person is diagnosed with cancer or diabetes, they have a conversation at some point with their doctor that says, here's the whole range of what could happen, here's the spectrum of possibility, and that's what we're asking for within epilepsy, is that you have that conversation that talks about all the possible outcomes, and then we as parents can say, okay, now I really want to hone in on this one, and tell me more about this, but to be educated at kind of a high level, to become aware, and then to go from there. So the risk of sudden death. And some of this I might be more scripted with, just because I want to make sure we share all the information. But we get a common question, what is SUDEP? What exactly is it? It's an acronym for sudden unexpected death in epilepsy. SUDEP is not a cause of death, rather a category of death. A death is referred to as SUDEP when a seemingly healthy person with epilepsy dies unexpectedly and no clear reason for the death can be determined. In most cases, an autopsy is required to rule out other causes of death. And there's a set of criteria that indicate whether it's a case of SUDEP or not. One, the person has epilepsy. Two, the person died unexpectedly while in an otherwise reasonable state of health. Three, the death occurred suddenly and during normal activity, so oftentimes that's sleep, like it was with my nephew. An obvious cause of death couldn't be found through an autopsy, and the death was not a result of status epilepticus, which you guys might know is just essentially a seizure that won't end on its own. So another question we get all the time, and I should say too, feel free to jump in and interrupt me with questions. We don't have to wait to the end, so just stop me at any time. What causes SUDEP? The short answer is we still don't really know. There's a lot of research that's going on. Obviously, there's three main theories that any of us could guess. You know, it's involving the heart, the brain, or respiration. And it seems likely that it might be some combination of those. And it also seems likely that it might not be the same for everybody. So what caused it for Danny might not be what causes it for somebody else.
Did Danny have any of those issues?
He had seizures at night. And we'll talk in a minute about some of the major risk factors. And he did have a few of those.
But did he have a heart thing?
Oh no. And when I say that, I mean, you know, what ultimately causes the death? Is it cardiac arrest, or is it, he didn't have any existing medical issues. I mean, like what actually causes the death. So respiration, something to do with the heart. Is it cardiac arrest, or is it, you know, brain failure? That's still being studied. Another question we get a lot is how often does it happen? This is a tricky question because one of the issues is a lot of medical examiners or coroners don't know what SUDEP is, and so the data collection is probably not what it could be. In other words, we think there's probably cases of SUDEP that are never described that way. So talking about the incidence is tricky. But what research has shown that we talk about is when the seizures are not controlled, it's about 1 in 150 people annually that will die from SUDEP, which is, to me, a really high number. It's frightening. If seizures are controlled by medication, that number changes to 1 in 1,000. So a big difference. So the takeaway for all of us being, you know, that seizure control is really important. And, you know, we know that seizure control is not reality for some people, you know, for some families. So the idea then becomes as few seizures as possible, whatever that means, you know. If it's a dozen down to, let's say, 2 a week, or, you know, if your family's experiencing dozens a day, maybe it's down to 10 a day. It's different for everybody, but the idea that fewer is better. So with children, it's believed that the incidence level is somewhat similar, 1 in 1,000, if the seizures are controlled. So the next thing we talk about in our risk factors, the biggest one I've already mentioned, and that's uncontrolled seizures. So the higher the volume, the higher the risk. Another big risk is tonic-clonic seizures at night, and that's what Danny had. So he didn't have a lot of seizures relative to other people, but he did have grand mal seizures in his sleep. So if we look at kind of a fuller list, seizures that can't be controlled, tonic-clonic seizures, a lack of treatment adherence. So if you're not taking your medication, it's believed that your risk goes up. Long-standing chronic epilepsy, seizures that happen during sleep, so Danny's case. Stopping the use of medications abruptly, as opposed to like weaning off of them. Developmental delays, and the onset of epilepsy at a young age. Those are all believed to be risk factors. So one thing we emphasize, it's important to talk to your doctor about your individual or tailored risk. You know, there's this set of general risks, but we advocate for parents to talk about the individual specific to your child. That's really important. So now I'm going to pass it over to my colleague Mary Duffy, who is going to talk about some of the ways we think we can minimize the risks.
Hi everybody, thanks for coming today. I'm part of the organization because my son was Danny's best friend, and I'm Mary Ann, which is Danny's mom's best friend. So I'm going to continue what Tom was talking about here. You're introduced to the word SUDEP and the risk now, so we ask that you take a few steps to educate yourself by talking with your doctors, and again, what Tom mentioned, tailoring your treatment to the type of seizures that your child is having or you yourself are having. There's a couple of, well, one thing I should mention too is just that a couple of conversations at the table I had already this morning, that's important to that doctors educate every family, so you might have to actually bring up the conversation to your doctor. And I say that because of what Tom said, that Danny only had 6 seizures in his life, so he might, to some people, be considered low risk and the subject might not be brought up. So it's important that all families are educated, and you might have to actually start that conversation. So next we're going to talk about, maybe I went too fast. Sorry. A couple of things, and kind of touching upon what Tom already mentioned. But some things, first of all, is just making sure that you have the seizure control that you deserve and that you need, and that you partner with your doctor to get to that level. Things, just reminders from many of us, is making sure that you take your seizure medication consistently, in the right dose. Make sure you're seeing your epilepsy doctor and all healthcare providers regularly. It does sound simple, but we do hear, we didn't have a chance to go last time, or we skipped one. So just making sure that that's very important to you and that it's on your calendar. Ensure that you or your loved one's getting enough sleep, limiting your alcohol intake and avoiding any type of recreational drugs, knowing yourself, knowing your triggers for your seizures, and doing everything you can to avoid that, changing your lifestyle, changing your environment if need be. Keeping yourself healthy, stress-free as much as you possibly can as well. And then of course, if medicines aren't working, speaking up and talking about with your doctor about different alternative treatments, maybe a dietary, a different diet, alternate therapies, or even surgery. If another step involving the family and friends too is ensure that family and friends and caregivers have knowledge on seizure first aid, as well as emergency resuscitation measures, defibrillators, and CPR. Okay. There's also a lot of ways you can track your seizures. There's a lot of applications out there right now and diaries, making sure that you note all of that. It's hard to remember at that doctor appointment what happened over the last 3 months, so that you jot down the triggers, side effects of the medicine, just really knowing your seizures inside and out, so that you and your doctor can come up with a good plan to make changes, perhaps if necessary. And then lastly, there's something there's out there called devices that you can use to detect and actually alert you to a seizure. So that's the next slide here. So we like to call it another resource, another tool in your tool belt, okay, to protect your loved one or protect yourself from any risks. A device, we should mention, doesn't replace a parent's instinct.
Any other questions regarding the epilepsy monitoring unit and the expectations for type of electrodes that may be used?
Was your son in for multiple days of the EEG?
Yeah, this last time he was in, it was supposed to be 24 hour, and then the EEG came back and he didn't have any seizures, and they didn't believe it, so they kept him another day.
Right.
And it was, actually they had treated the epileptic encephalopathy well enough that.
Perfect. And so that is one of the utilizations of an EEG to help guide the physician when they're interpreting. They may see something and then they add a medication, and then they would want to make sure that the waveforms that they saw earlier that were causing the seizures are now abolished based on the medication that was given, and that's exactly one of the main roles for an EEG. And it's having a technologist that's knowledgeable and to help provide your interpreting physician or epileptologist with that information.
The biggest challenge we have is he's had EEGs done at our regional medical center in Spokane, and then he goes to UCSF and they can't read what the other EEG that's been done because it's a different system or something.
Correct. You are not alone.
And you can't just hit print.
Right. There are some options. There's third-party softwares, but the facilities need to have that to be able to interpret it. Hopefully, there is some type of interpretation, a report from a physician to help guide, even though you don't have the physical EEG itself.
Last time when he had epileptic encephalopathy, our regional center read the EEG one way and San Francisco interpreted it a different way.
Yes.
That was super
So those are some of the differences and variabilities of education, knowledge, credentialing, board certified, and that's one of the things that we promote on a national level.
Zebras. San Francisco deals with zebras.
Very, very true. Very true. Good point. That's a very good point. You've done your homework and you've been researching, which is wonderful. And that's one of the things I think this venue is wonderful. It adds heightened awareness to what Brad is trying to do here to educate and make everyone knowledgeable of what opportunities are out there. And this is a wonderful venue for community and support. And you might discover there's things out here and you're not alone, right? And other people may be affected by it, and you can network that way. And I think this, or you might find another avenue that you didn't even know existed to help get treatment. Very true.
The other thing too is to take the information back to your physician and educate them, because sometimes they're in a bubble and they don't even know what's new and what's come across the pike. So sometimes that can really help as well.
Thank you for the information. What hospital do you go to?
Gritman Medical Center is in Moscow.
Yeah.
And then there's Pullman Regional Medical Center, and then there's
St. Joe's.
St. Joe's in Lewiston. That's right. About 45 minutes out.
Right. So it's having the capability of 24-hour support to be able to provide the service. And a lot of the larger centers have that. It's then when the smaller centers don't have that capability, what are the options for you? And so there's vendors, there's companies, they're all working together and getting that information to neurologists or epileptologists so they can better have resources and tools to help treat their patients. So that's very true.
Do you get to see your physician pretty much anytime you wish to? Your neurologist.
Our neurologist?
Well, your neurologist.
Probably if we wanted to, but because they're in San Francisco and we're in Idaho. It takes a bit of...
Because we're finding that where we're at, there's only one neurologist at Children's Hospital.
Oh.
So it's, he's where is that? Fresno. Well,
Fresno.
Children's Hospital is actually it's Madera County.
Right.
But he's just, and I can understand why.
Right.
He has so many patients. He's the only one there. So.
Right. There are some options for telehealth that's being rolled out, which I think is very helpful for patients and physicians to connect. If they're 6 hours away, what can you do to pre-screen or have that sort of one-on-one? And telehealth helps with that. So that's something you can probably maybe take back to your physician and see if that's an opportunity, especially if they're going to send you for a second opinion. Where can you go? If you're in Fresno and you want to reach out to one of the organizations or hospitals in the Bay Area, do they offer telehealth first to have that initial consult?
It's a great resource.
Yeah.
Yeah, it's a great venue here. It really is to get information. Ask everyone. I mean,
Is there like a how to read the screen cheat sheet?
So for
what?
You mean the EEG itself? If you go to our booth, I actually have an EEG scrolling, but the technologists, I can give you more information. Technologists, they should be trained. There's education, there's schools, right?
Well, I just want to know as a parent when I'm sitting in the room and I see stuff, I kind of want to know what.
That's an interesting concept.
I could simple things like eye blinks, muscle artifact.
Yeah.
I have that.
Yeah.
Okay.
It's a great.
And like a background, like
Yeah,
there's
so
normal
he's got-
background.
yeah, we don't. So that's one thing that we don't understand at all is the background. So he had poor organization, and then was upgraded to disorganization, and had periods of organization.
Right.
I tried googling those terms, and I got nothing. I'm like, what does that mean? What is organization? And why would he have periods of organization during sleep, and then no periods of organization awake? But he's walking and talking and what does organization mean? And I thought it was like when your brain is firing, like from point A to point B. Those are like if you can get to point B, then it's organized.
Well, and there's different brain waves that are normal for every age. So a newborn, as we can see with the newborn or a young baby, they don't have the motor skills, they can't talk. And obviously when you look at that, if you think about how their brain is developed, it's not as developed as your older son or us. So there's different levels of normal on the EEG. And so you kind of have to be educated from neonatal, pediatric, adult to all the normal backgrounds, organized backgrounds. And if they're not organized, then they have to decide what is different about this EEG. Let's go down that avenue, and they're trying to figure out how to diagnose it. So basically the EEG is an EKG of the brain. You know, EKG, we all can look at that and tell it's a heart beating or it's a funny looking heartbeat. Well, there's a whole bunch of electrodes on the brain so it's a lot more in depth.
But what is organization?
Well, depending on how old was he at the time?
4.
So maybe in the period of organization, that was maybe where it was more normal for his age. And then when it's disorganized, that would be maybe in the gray area. I don't know if he was having seizures at that time or staring spells or something like that they could relate any of his behaviors to the brainwaves. But usually the disorganization is not necessarily normal. There's certain patterns for pediatrics. Disorganization is normal. You expect that at certain ages. Like if they do deep breathing, if they have them do the hyperventilation as they get older, that will change the background, and it's called an activation procedure. The reason they do that is, unfortunately, to bring out abnormalities because you want to see that on the EEG when you're recording it. Photic stimulation, the flashing light, that's another activation. One of the main activations is sleep. So if you go in for 20 minutes, you're really not going to get into a deep stage of sleep, and that's why people do the 24-hour ambulatories or in the hospital extended EEGs, because sleep a lot of times will show the abnormalities where the patient could be awake all day long and you never see an abnormality. But as soon as they go to sleep, in and out of the stages, you see it over and over again. So, you ask, why does my kid have to be monitored for 3 days? The first day might not be enough. They might catch it on the third day.
So there's actually a lot of causes about why you can have epilepsy too. When I say post-injury, it's usually a severe injury, like a car accident. Most times you don't have epilepsy post-traumatic after like a regular concussion. These are usually severe injuries. And metabolic, a lot of times you can figure that out through genetic testing too, but there are certain metabolic tests as well. Okay. On structural, I didn't mention there's also a MEG scan. Anybody ever hear of the MEG scan? No. So that's another tool that's helpful when doing looking for epilepsy surgery options. They look at the magnetic waves, and it helps pinpoint where you suspect where the seizures are coming from. Okay. I know UCSF has a MEG scanner. I think San Diego does. At UCLA we don't have a scanner, but we send our patients to UCSF. They do a MEG scan, and then we get the results. Okay. So that's also an option. Now, for other reasons why, other testing that we do, the main one is the EEG. Just because the EEG can show you where you suspect seizures are coming from. Is it from one spot versus the whole brain? Some EEG patterns have a very typical pattern, like Epson seizures have a classic 3 Hz spike wave pattern that makes you suspicious for that. Benign Rolandic epilepsy has another pattern that makes you suspicious for it. So based on the history as well as the EEG, you kind of have a good idea about what kind of seizures you might be having. Okay. What questions do you guys have about anything on this board? Please.
We have a neurologist and a neurosurgeon.
Sure.
But we don't have a you. Like, why would, I mean, what's the value? I mean, I know you're, but why would we would go get another doctor?
Yeah, so it depends on your neurologist if they're comfortable with epilepsy. So some neurologists have specialties in different options. So some neurologists do autism, some do neuromuscular, like muscular dystrophy and that kind of neurology. Some specialize just in stroke or other kind of things that fall within neurology. I think epileptologists, my training was in reading EEGs and working just kids up with epilepsy. That's kind of what all I do. So that's kind of.
So at what point would you go? I mean, we have an epileptologist.
Yeah.
So we were just given an epileptologist. So, but at what point would you usually move from a neurologist to an epileptologist?
If the seizures are very difficult to control, if you're at a point where you've tried 2 medications and you're definitely not having great control, and you want to consider doing pre-surgical evaluation to see if there's a structural cause or something that you can do epilepsy surgery with, then I would probably see an epileptologist at that point. So when we meet as a team, we meet with the neurosurgeon, Dr. Fala. We meet with neuropsychology. We meet with neuroradiology. We meet with a bunch of different people. It's at a conference that we do on Wednesdays as a team, where we go over the cases to see whether you're a good surgical candidate or not. So when it's my patient, I present their case and I present their EEG, and we look at it as a whole team. And we say, okay, yes, you're likely can benefit from surgery or you can't. So often within even our UCLA, the neurologist will tell the epileptologist, I think this is a good surgical candidate. Do you mind working them up and see if they will benefit from surgery?
For each person, it is different because our bodies need different amounts of calories based on our activity level, based on everything. So that's another reason why I recommend going to see someone, because it might differ, and you might benefit from a different amount than another person. But the generic guidelines for adults is anywhere between 20 to 30 grams of net carbohydrates a day.
That would be, is that a regular ketogenic, not a modified?
That would be more of a modified.
She's on 15, so
she's a bit
straight keto, and she's 15.
20. Yeah.
Okay.
And I have some people on. They tend to be younger, on lower grams, like around 10. But some of them are on 30, and I have some on 30 or 45 too, because they're really active and they require more calories. And as long as, what's interesting is each person responds individually to different levels of ketosis. So it might take some adjusting to figure out what level is appropriate for you. So like 15 works, 15 grams works for you. I have a patient who's seizure free on 45. So each person is very different.
But that's with the subtraction of the fiber.
Yes, we do net. So you can get more.
Otherwise, you wouldn't be able to have chia pie.
Yes.
Which is really high in carbs, but it's like the same amount in fiber.
Okay, and then what about the fat?
The fat?
Like, so how many grams of fat are you talking about?
A lot.
I mean, a lot isn't a number.
Exactly. I know I was being vague because it's very different.
With the protein, like they're both high, or?
Protein is adequate. So if you eat too much protein, you can actually knock yourself out of ketosis. So, and so that actually, we calculate it based on your weight, the kind of amount of protein you should aim for. I typically provide a range to be like, you should aim for this is the healthy amount for you. I typically, as far as fat, it's really hard to provide a number because calories are so variable for other people. But I would love to hear.
20 grams of carbs, 70 of protein. You take those two, add them up, right? That's 90, and then like 180 to 200 of fat. So we took and he's 6 feet tall, right?
Yeah.
So we would take the 20 carbs and spread them out throughout the day to say 5 per meal, right? Breakfast, lunch, and dinner, and then 2 or 3 per snack each, and then that's it.
More like 40-50 for protein for someone that's smaller.
Yeah, it depends on your weight.
And then the fat, you said 200.
So I would do 1.5 to 2 times the amount of fat. When you add the grams of carbs and protein together, I would do anywhere between. Actually, I'm going to take this back. Your ratio or in the amount of calories, I would just do 1 to 2 times the amount of fat.
I think the importance of seeing a doctor, because even when he dropped the weight, they adjusted it. Dropped even more weight, they adjusted it. So it really is like you can't take his number and say, I feel like I'm half this weight, I'll just laugh it.
That's why working with someone is really important.
Do they have calculators online? I'm just curious.
The one calculator that I use is institution specific and reserved for dietitians. But the apps like Carbmaster, you should be able to figure out, at least be able to figure out a low carb, high fat diet to start off with. So you will be eating less total protein because for a regular diet, we actually eat significantly more protein than, and once you start this, you're going to be like, oh my goodness, I've been eating that much protein, and all I necessarily need to maintain lean body mass and for growth of a 15-year-old is this amount. You can mix it with some butter and some heavy cream, depending on what vegetable your child might like, or it could be fruits, or we can find some other carb base. Use that. You have to measure that. I like to throw out tomatoes, but not every kid. I hated tomatoes when I was growing up. It took a long time. What vegetables would they like? Or you can have a few raspberries on the side. Do that. And with a side of milk, but milk is some heavy whipping cream with some water in it, so it gives more of the appearance of milk. And you can have a couple slices of bacon too. And you would weigh each ingredient separately and then prepare it and put it on a plate for your child. So it is essentially like short order cooking, but the position, what you can reach the highest amount of ketones, which is what we think is protective about the diet, what helps the seizures, are those ketones. I should have explained that too prior to just jumping into what the diets were. I'll address that and why we think how this changes. Any other questions about, oh, no, that's not a full day, that's one meal.
Okay.
Lunch, what you can do is some meat and some lettuce rolled up, maybe some cheese, put some mayonnaise in it, little like turkey roll-ups or something like that. Trying to get fat in can be challenging. You can choose, there are some things called pepperoni pizzas where you do little pepperonis with some cheese on top, a little bit of oil and tomato sauce. I'm a huge advocate for the heavy whipping cream as a milk, or there are some Pediasure-like keto drinks that are available to grab and go. You can have that on the side. And for dinner, it could be a piece of chicken with some broccoli or carrots on the side with butter, oil drizzled over it. Or you can make a pesto and drizzle it over it. You can use Alfredo, mix some oil on it. You can spiralize zucchini, make it noodles. You can rice cauliflower, make that into a nice side. For dessert, you can make some ice cream from heavy whipping cream and sugar-free Jell-O, and it freezes fairly nicely. There's also some recipes for chocolate mousse that you can try. I know that there's this new chocolate mousse from one company that's coming out on the market soon. I don't know when, but it's honestly really good. It depends on the person. And you would need to make sure that it's also high in fat.
And when you're seeking to control seizures from this diet, are you looking at the most strict form of this diet primarily when the seizures are almost exclusively controlled by diet as opposed to a combination of diet and medication, or a certain type of epilepsy it's more effective with?
Each child responds differently. So it helps, most of the studies are done on children who don't respond to medications. Not that I think that it couldn't be provided as a first line, but that's all of our studies are done on children who have not reached seizure freedom on medications. And so it depends on the child. The goal is always seizure freedom, but the diet works for probably about 2/3 of the people who try it in cutting half of the amount of seizures. And then 1/3 of the people who try it, of the children who try it, can improve their seizures by 90%. And then anywhere between 10 and 15% children can become seizure free. The diet, we have found certain syndromes and certain type of epilepsies respond better than others. The ones that respond really well, in our experience, have been Doucet and Dravet. But really any type of generalized epilepsy, even absence epilepsy, we have seen in our program really good improvements with seizure control.
To localize. When you're crossing the street, how do you cross the street? You hear the car coming first, right? And then you turn your head to see it. So very important in school for them to assess your child's auditory processing ability. Typically the child has to be 7 years old to do that and also have a normal IQ. So if your child has a below average IQ or is younger than 7, they probably are not qualified yet or can't have this auditory processing assessment. It's also really important for learning how to read, because reading is primarily a function of learning the sounds first before you learn the letters. If your child has poor auditory processing skills, learning how to read is going to be very challenging. So that is another reason why the school has to conduct this assessment. The school is definitely going to tell you, we don't do that here. So what are you guys going to say? Find someone who does. That's right. You may have this covered by your private insurance. I have found that school district audiologists, many of them typically don't really understand this too much. So if you have the coverage under your insurance policy, or you can afford an independent audiological examination, it's worth the money. I think it's about $900 to do that locally. That's just your temporal lobe, that's your auditory cortex. So it's just to tell you that it's important if you have any kind of temporal lobe epilepsy or if you've had it removed to look at the audiology piece. Just quickly, these are all the different types of things you do with sound. Dichotic listening, I explained. One conversation is here, another conversation is here. Your brain is able to filter that out. What's the loudest environment with the most noise that you can think of? playground, kindergarten classroom. Those kids are loud, there are a lot of voices, and if your child has a difficult time with dichotic listening or processing sound, it's going to be really hard to learn in a loud and boisterous environment. And what we're doing here is priming the school to understand that intensive instruction, reading interventions, those kinds of things should be done in a quiet room outside of the loud classroom. This is easy. Everybody's probably heard of a gross motor assessment. This is what your physical therapist does. They're really going to look at large body movements, jumping, kicking, coordination. Most schools tend to do this pretty well. I think for us with hemispherectomy it's really complicated, but I so far have been pretty happy with what the schools can do with that. Fine motor is small, the small muscles of your hand. You want to look at your child's grip strength. That should be assessed in a fine motor assessment. Pressure, how they write, whether they have dysgraphia. So some children may have trouble forming letters correctly. You want all of this picked up in that fine motor assessment that's typically done by the occupational therapist. Definitely after hemispherectomy. In the unaffected hand, you're going to have grip problems and you're going to have problems with writing. So something for them to look at. Speech. My son doesn't talk, so obviously a speech assessment is going to reveal that. Those of you who do have children who are verbal, partially verbal, you still want to have a speech assessment because you want to understand their receptive speech, what they understand in terms of vocabulary, and then how they express themselves, how they articulate. And I've circled pragmatics because many children with epilepsy, many children with intellectual challenges have trouble with pragmatics of conversation, and that is the give and take of everyday conversation. When do you say something? When do you say hello? When do you pause to give the speaker a chance to respond? These are the things that affect how you make friends as you get older, and they affect your ability to get a job. If you're unable to engage in the normal everyday conversations that you have with other human beings, it can impact your life in a pretty significant way. So even if your kid can talk and talks pretty well, you really want them to look at pragmatics of conversation. So, hopefully they can work. Augmentative assisted communication. Even if your child speaks, they may need some help with communicating their needs depending on their intellectual level. So you want them to look at their speaking ability as well as their writing. Some of these kids don't write well, so the augmentative assistive communication device can help them with that. This is a separate assessment that the school should conduct. Assistive technology. An assistive technology assessment can reveal what your kid needs to kind of help them in school. And assistive technology can be something really basic, like a timer to help them understand when they should stop studying or when they need to get a break. And it can be something extremely complicated, like an iPad for communication. My son's on an iPad with a special app for communication. All this is going to be fleshed out in an assistive technology evaluation, which you're entitled to have.
Or you become amnestic, like patient HM. And so so we actually put in the RNS in him, and his seizures are now better controlled because of that. But again, he's a surgical failure in a sense, but we reevaluate it. So not every single person can have a repeat surgery, but RNS is certainly an option. And the third patient actually, same scenario, had a temporal lobectomy, but the surgeon left this part of the brain, the called the superior temporal gyrus, and then we monitor the patient, and it turned out that the seizures came from the same side. We actually didn't put in invasive electrodes, but we thought that the risk of cleaning out all that scar tissue was so low that we're not going to put in the depth electrodes. And we got this whole side cleaned out. And again, she's been seizure-free for about 6 months now. She was having fairly frequent weekly seizures. So there are things you can do. There may be things you can do after a surgical failure, but it doesn't mean that this is the last thing you can do.
The scar tissue part, because that's there's the two reasons why, or many why I'm not able to have repeat surgery, because I would lose more sight or become completely blind in my motor or visual skills and whatnot, and I have multiple foci. But is it, and the depth, because they started when I was a day old. So what would you would you even consider trying to clear scar tissue out if you were to do those little needles, or what would your thought be?
It depends on where the seizures are coming from. If the seizures come from areas of the brain that is important for vision or speech, then we will probably put in the RNS in those areas. But that's an assumption. I mean, remember this guy who had surgery at Barrows with multiple, with two lesions, right behind the motor cortex. And we thought for sure that the seizure had to come from that area. And we won't be able to do any more, but the seizure actually came from the hippocampus. So.
And something else that I heard at a conference in Toronto made me think about the hippocampus for myself. So that's why I'm just curious about that.
I mean, there's no free lunch. I mean, any part of the brain you take out, essentially you can't have some sort of, deficit. But the question is this risk, and this is a worth it kind of a question, right? Is the mild amount of, especially non-dominant temporal lobe, people tend to do pretty well. Even dominant temporal lobe, if there's scar tissue there already, you can't make people worse. And so therefore, that's a discussion you should be having with your doctor.
Implement the RNS for the subjects who have the temporal lobe. What effect does that have on memory?
Very little. In fact, they've now done studies on cognitive studies on people with RNS, and there's very little side effects in terms of memory. Because you're not taking anything out, you're actually just stimulating these structures. There's really no side effect on memory cognition.
How many sections can the RNS go into? Just two, okay.
Two. You can have 3 wires implanted, but only 2 can be connected with the current system. Okay. Now the other thing that we've done is that we actually, if somebody who hasn't had surgery and the seizure comes from both hippocampi, we actually have, let's say if 90% of the seizure came from this side and only 10% came from this side, right? So the majority came from the right side. So we actually have done a resection of the 90% side and put in the RNS for the 10% side. And that makes that for us actually we've gotten better seizure control than we're just putting bilateral RNS.
Is that something that you can tell from the whole workup coming up to the surgery?
We actually record many seizures while the patient's having intracranial monitoring, just to figure out what is the right proportion. One of the things that we discover more and more is that a lot of patients are actually having bilateral seizures, because if you're just in the epilepsy monitoring unit and just getting monitored, and then your doctor records 3 seizures, then how do you tell the 4th one then come from the other side? So it's all a sampling issue. We try to sample reasonably as many seizures as we can. Usually you need about 5 seizures trying to figure out whether or not one side is really consistent. The old school was like 3 seizures, but really you need more than that, trying to figure out whether there's a consistency or not.
Once you discover that there is something like this happening within your family anywhere, then it makes good sense that you have genetic testing, so carrier testing of other members of the family to figure out which line through that family those mutations are passed on. Because then, if people know what their whether they're a carrier or not, that will inform their decisions about having children later in life.
But there's no way to change the gene mutation in the parent so then they're no longer a carrier.
No,
Okay, gotta ask.
That's not possible as yet.
Yeah.
That's one of those things that in those newspaper reports was tantalizingly dangled that it might be a possibility one day out there in science fiction land. But you know, we don't live in science fiction land yet.
Over by the entrance.
And we're trying to figure out what we can do.
Hello, Mickey.
With current technology. Yeah? And with current technology, I know that people will be working on ways to try and correct those defects in a mouse. We know that it's possible to correct defects in cells on a dish, but will it be possible to do that in a whole brain?
Yeah.
We don't know as yet. And those are things that become exciting possibilities as technology comes along. We also have to be very wary that they have their ethical implications as well. So having the ability to manipulate cells or, for example, use stem cells, these things all come at a price, you know, and we have to consider which is the best, sensible, and most ethical approach to do any of our science as we move forwards. And a very interesting ethical question that has come out is that obviously knowing about these diseases at a very early stage would be best, because our chances of treatment are much highest if we know about them early, which raises the whole question of newborn screening. But see, for example, you can't really screen for something in a newborn if you don't have a means of treating it. That's a very difficult ethical ground to be on. You could screen everybody for every mutation, but you would not know if you don't have the ability to do something about it. That's not a world I wish to be living in. So now, with CLN2 disease, we actually have the ability that we can intervene, and there is an FDA-approved therapy. So it raises the question whether screening for CLN2 would actually be a sensible thing to do, and whether that is something which is now feasible. There are lots of implications to come out of it, because in that screening process for CLN2, we might find that that particular family had CLN1, and we can't currently treat CLN1. So it's kind of a chicken and the egg situation. We're kind of catch-22. We're in a place where we can do some things, but we can't do other things. And that makes it quite complicated. I mean, certainly where we are now is a much better place that we actually have something that we can intervene in one of these forms of the disease, which is certainly very different from when I started a number of years ago. We clearly have a lot more work to do to get to the same place with all the other forms, and that's what we're actually doing. So you asked some questions about a variety of different drugs or compounds that you might use to intervene, and in some of those situations, for the forms that aren't a Pac-Man, for the forms that are, there's our lysosome, the thing that's sitting in the wall of it. Now, if we knew what that did, what molecular pathway, what biological process inside the cell it worked in normally, we would be able to do something about fixing that problem. But despite many people much cleverer than me working on it for many years, we still have not a lot of an idea about what that normally does. And if you don't know what it normally does, it makes it very tricky to figure out how you're going to fix it. So what people do is they look at a model that has the same mistake, and they look at all the possible things that are happening in that model. So some of those things will be really important things, and some of them will be like a cascade of badness that's trickling down. And some of the things you might identify and try and treat with a drug, you say, oh, I see that there is a problem with mitochondria, and treat with a drug that you know might have a positive effect on it. Or you might look at them and say, there's oxidative stress going on, and try to block that. Or we've done a lot of work looking at the brain's immune system, and so we treat with anti-inflammatory drugs, or we treat with immunosuppressant drugs. Now all of those, if they're a long way away, if they're something that affects way downstream of the original problem, they may have a small positive effect, but they're not addressing the underlying cause.
You can have epilepsy of one entire half of your brain, and we do surgery for that. We take out half of the brain. So it really is something that is very specific to each person. You know, there's no two epilepsies that are the same.
What's the best situation to use the gamma knife technique?
So gamma knife. The question is, when do you use the gamma knife? So the gamma knife is right now. It's not really. The best use of it is when you have mesial temporal sclerosis, so a type of temporal lobe epilepsy. So in doing that, it saves any kind of open surgery. That would be one use for it. But in general, if you were to say, you know, is that a good option? I would recommend in the setting of for most people, one of the other options is a first line over doing that surgery.
So when you have the RNS implanted, you maintain all of your neuro status as the same it was before?
Yeah. So the question is, if you have the RNS implanted, do you maintain the same level of your neurocognitive status? And the answer is yes. The device doesn't do any, you know, it's not resective, it doesn't change the brain other than to shock that area. And sometimes we see that people's seizures go down just over time. But overall, it doesn't have any long-term major changes to people. Now, that being said, you could make that same argument for a lot of people who have temporal lobectomy or resection or whatever, because a lot of those people they are very similar to how they went to sleep or the same. So it's not just RNS or VNS that does that. Any other questions?
I have a question. How many people that have RNS end up with still being on medication? What percentage?
I would say probably most of them do. RNS is not I mean, like a pacemaker, a lot of people who have pacemakers still have to take some kind of heart medicine, because it's an additional step. It's not the only treatment. It's one of several. With the laser, you can, yeah, in certain cases. Same with resection. Same with that, yeah. I mean, with a VNS and RNS, very unlikely. But with resection, ablation, laser we talked about, DBS possibly in the future, and then gamma knife as well, same kind of thing.
But you won't have to be on as many?
Again, it's hard to say. That's not 100%. There are people that don't respond, and so it's one of those things where it kind of depends on how you do with it. I would say though that in my experience, the patients we've operated on, we've done a lot, and those patients do very well. I say that a lot of some patients we implant the electrodes, and the device we leave it off for about a month. And even while it's off, their seizures go down just from the implantation. And I've had patients where 8 months go by and they don't have a seizure, and all they have is just the implantation. It's not even turned on yet. It's something about the implantation effect. So just having those leads on that part of the brain, and that irritating or that doing whatever it's doing to that area is enough to sometimes decrease or stop seizures for a long period of time. Similar to when you take a new medicine and your seizures go down, honeymoon period, similar to that. It's very similar.
You said that seizures, of course, cause the brain to change, right? And I was wondering, since the VNS and the RNS, they send stimulation. I was wondering if the stimulation causes different changes.
Yeah. So
would that be positive or negative? I mean, it should be positive, right?
So it's a great question. So the question was, if you have vagus nerve stimulation or responsive neurostimulation, and it's sending these shocks to the brain, does that change the brain? Does that change the connections? And if so, is that good or bad? And I think, that's a very good question. It's a hard question to answer because we really have we're still learning a lot about how these devices work. Now, with that being said, in general, yeah, the vagus nerve stimulator is thought to be how it works. So by stimulating the vagus nerve, that causes some sort of changes in the brain connections, and over time we see that people sometimes have seizure reduction related to that, those changes in the connections in the brain. Same way with the RNS. Over time, if it sends these shocks or it's changing the way the seizures are treated, we can see sometimes people have reduction in their seizures. Now, it may be that the device is shocking the brain and that's stopping the seizures from going forward. We don't know that, but regardless, the brain does have some changes that occur when you get stimulation.
45 minutes. He has zero muscle control. He can't look at you. He can't anything. It takes about 45 minutes to an hour for him to even be able to focus. And it takes him an additional 24 hours to be able to have 50% motor control. And then another 48 hours to get to like 75%. So, I mean, the after effects are very traditional, they say, of seizures. His seizures aren't super dramatic, at least the ones that we've seen, but they are exactly the same every single time. And they're nighttime, except for the 2 to 4 that we have just started happening during the day. But we just kind of don't know, like, where do we go next? We are trying to get transferred over to the group that specializes in seizures, so maybe we'll have more information there. But we get so much different information from everybody.
It's hard, right? Because that's the one thing in epilepsy we don't agree on very much. It's hard to get us all to agree. I mean, it's hard without actually seeing the information, but genetic testing probably needs to be done. Microarray is just like a cursory overview, like it's looking at genetics from an airplane, not like right down in the land. So you need the actual epilepsy genetic testing. If you can get a diagnosis, then that's going to give you the answer, right? Because that tells us exactly what we need to do. So that's definitely something that you need to do. And then the EEGs were completely normal.
But he's not during a seizure.
Right. Yeah, it makes it a little harder when there's not a seizure. I mean, probably not having heard everything exactly. It's probably sometimes when we have seizures, even if the EEG is normal, we try treatment to see if we can get things better. So that's probably the next best step, is to try some type of treatment that would be right for the seizure type we think we're having, to see if we can stop the regression that you're seeing after all the seizures. But genetic testing is probably the next best step, to try to get an underlying answer to see if we can figure out what's going on.
It's been delays episodes, so he was ahead. We don't know. Yeah, and she was too, and we don't know why.
There's a lot of genetic diseases where you have normal development and then you lose. I mean, that's the classic for Dravet's, with normal development and then loss of development. And people don't understand, if you're born with a genetic disease, how can you have normal development and then lose it? But that's the hallmark of some of the genetic diseases, that you're actually, that's the criteria for meeting the genetic diseases, that you have to have normal development till a certain age and then you lose your development. There's some diseases where you're normal till teenager, and then that's when the disease hits you, and that's when you lose your development and have your bad epilepsy. So just because we say it's a genetic disease doesn't mean you have symptoms of birth. There's genetic diseases that present across the lifespan. So it's not just because you're born with a genetic disease doesn't mean you present when you're born. You can present throughout the lifespan. That's just the way genetics is. You can present at any time. So the genetics is changing the way we practice medicine. It's really the most important thing in epilepsy right now, is genetic testing and these genetic diagnoses. The way it changes for Dravet's disease, for example, Dravet's is an abnormality of the sodium channel. And it's a very interesting disease because kids present initially with febrile seizures, and then they have focal seizures. And when you have focal seizures, the medications for people who have been in the epilepsy world for a while, you think of medicines like Tegretol and Triliptal. Those are our kind of mainstay focal drugs. That's why they put your child on Triliptal, because it's a focal drug. If you give somebody with Dravet's Tegretol or Triliptal, you put them into status, which is a really bad thing to do. But they have focal seizures, that's what you would normally use. So if you don't have genetic testing, you by mistake, trying to do the right thing because they have focal seizures, put the child on the completely wrong drug and actually cause harm, because you put them into status epilepticus, which is life-threatening. Whereas if you had the genetic testing, you would have completely avoided those drugs because you knew that's not the drug for those children. The other disease that genetic testing really changes is glucose transporter. So GLUT1, I think there's a table down there for the GLUT1 patients. These patients have a defect in the glucose transporter gene. They can't get sugar from their blood to their spinal fluid, so their brain is starving for sugar. And if those kids have to be on the ketogenic diet. No medication works at all. Their brain needs another source of energy. You put them on the diet, they switch from using sugar for energy to using ketones for energy, and then their brain works just fine. And instead of having intractable seizures, they do great. But you have to be able to diagnose that. So without genetic testing, you don't know these things. And you may not get to ketogenic diet until they failed 5, 10, 12 drugs, when that was the treatment they needed. So genetic testing makes a big difference.
Spinal tap,
yeah, so you can see a low sugar on the spinal tap. That's like the red flag. That's the warning if someone thinks to do a spinal tap. But not everybody thinks to do it in new onset seizures. And sometimes it's not as low as you think. There's some patients who have a defective glucose transporter. It's not 100% wiped out. It's just partially wiped out. And their CSF glucose is actually pretty close to normal. So, yeah, there's a new form. So now that we have gene testing, we find all these new things. So the classic glucose transporter defect presents in babies. And they seize right away in the first few months of life. There's now a variant where they present as teenagers. And instead of having neonatal seizures, they have generalized epilepsy as teenagers. And they have, instead of a complete absence of the transporter gene, is just defective. So it's a little slow getting across. Some sugar gets across, but not enough. And those patients present later in life, but they still have the same gene defect. So it's another disease that you wouldn't normally think about. So they have what looks like straightforward absence epilepsy, which is usually an easy seizure type to treat, but they don't respond to drugs. You put those patients on the diet, seizure free. But you wouldn't normally think about that, and nobody would probably do an LP on a normal child presenting with absence seizures, right? That's like an easy treatment. We don't usually tap those kids. But we now genetic test almost everybody. If they don't have a known diagnosis, we're genetic testing everybody now.
How often do you change that's changing?
Oh, almost every time. So almost every genetic test changes what,
Right, so is it like every 6 months? My kid doesn't have a diagnosis. She's epileptic, but we have no cause. So do you test her every 6 months?
Yeah, so everybody without a cause gets genetic testing, and then our lab automatically rescreens that DNA whenever new genes come out. It's done automatically by the lab once they have the DNA. So you don't have to submit another DNA sample. Right, so in every genetic lab should do that. So before you give your DNA to a genetic lab, you should ask them. Because what we had just happened recently, it can go both ways. So what happens is when you get genetic testing, it's actually really complicated. So some genes come back truly abnormal. So this is definitely disease causing. Some come back, this is completely benign. And then most of them come back saying, I don't know what this is. This is something is abnormal, but we don't know what it means. We don't have enough information yet. And those are the hard ones. Then you have to look and say, well, does this disease fit what the child presents like, or does this not fit? And then the doctor and the geneticist have to try to figure it out. And sometimes we look and see what it's doing to the protein, what it's doing to the body. We say, yeah, this looks like it's disease causing. It fits what my child has. I'm going to assume this is real. And then sometime down the line, 6 months later, a year later, 3 months later, then they'll say, okay, now we have enough information in the world to say this is disease causing. Or they'll come back and say, okay, this one's been ruled benign. And that can make a big difference. We had a family recently where it was a Draves family. She had 2 mutations in the Draves gene. We didn't know which one was disease causing. The father carried one, and they wanted to have another baby. So about a year after the testing, the lab came back and said, oh, that one the father carried has now been classified as benign. So now they can have another child, not worried about passing that gene down. And the lab just does that automatically. A good lab does that. Not good labs don't do that, but that's important to know whether it turns into disease causing or benign. Either way, you want to know.
You'll hear people talk about taking an isolate. An isolate would mean just one molecule or just one molecule of CBD only. This is not something that we, as people who do a lot of anecdotal research and scientific research, recommend for patients who are very ill. It can have some therapeutic benefits, but we truly believe in the whole plant approach. Now, our research is telling us in Israel that you don't need every single compound that's in that plant, but you do need enough to create what we call an entourage effect. And that's where you have cannabinoids, terpenoids, and flavonoids. Terpenoids and flavonoids being 2 other of the different types of ingredients in the cannabis plant, and they all work beautifully together to help counteract these imbalances and eradicate specific diseases. In cancer, it's called apoptosis or cell suicide. Now I want to talk a little bit about these 2 molecules because these are the ones you're going to hear the most about, THC and CBD. THC is psychoactive. This is what everybody is used to hearing about when you're smoking a joint. It gets you high, or taking an edible. It can also be a very, very therapeutic compound. You'll see a lot of information floating around in these state initiatives that are CBD only. I don't recommend getting behind CBD only laws unless you're in a state where you have a legal system where there's absolutely zero chance of them passing through THC. It is something that you need to fight for if this is an area or if you're in a state where they're trying to do this. THC can be so wonderful for so many things: anti-inflammatory, anti-epileptic, anti-nausea, anti-stress. There's just a number of these different issues that this can resolve and soften and calm down. But it's all about knowing how to use it responsibly. THC can be extremely potent, it can make you very uncomfortable, and it's not something I ever recommend using unless you have someone that understands how to dose this medicine, an expert caregiver, or again, medical professional that can walk you through this process and write you a titration protocol. What that means is, just like with most epilepsy medications, you're going to start low and you're going to work up until you find the relief you're looking for. That is the same situation with cannabis. And again, one patient is not going to respond the same as another. CBD is the non-psychoactive cannabidiol. This is a separate strain completely. There are oftentimes when you're working with a whole plant cannabis, there's going to be a little bit of THC in there. If you're working with hemp, it's 0.03% or lower THC. We work with cannabis. We don't work with hemp. Hemp can be therapeutic for epileptic patients, and in states where that's all you can get, absolutely go for it, because you got to try what you got to try. If you're in a legal state, we do recommend starting with a whole plant cannabis first with a low THC percentage. We normally like to start with a 20-to-1. 20-to-1 means 20 parts CBD to 1 part THC. So again, very, very minuscule doses. So low, in fact, that we don't see patients becoming psychoactive from this CBD. THCA is very new to the industry at large when it comes to medical. We are seeing an enormous amount of therapeutic value in THCA. The A, again, stands for acid. So you understand what the difference is between THCA and a delta-9 psychoactive THC. The psychoactive THC has been heated at a high temperature, and that's what activates that molecule and gives you that stony effect. THCA, the way that that's processed is we take organic, lab-tested, 100% clean flower, and we soak it in an olive oil bath at a low heat of 140 degrees. The oil doesn't even get hot. And because it's at such a low temperature, it extracts all of the cannabinoids, terpenoids, and flavonoids from that flower and leaves it behind in the olive oil bath. We then strain the flower and we use that as a treatment option, which with autism we've seen incredible research or incredible results anecdotally, and we're actually planning human trials with one of the top pediatric hospitals in the country, #1 in California. It is very therapeutic based on what we are seeing, and we're excited to see where the research goes to help us uncover what else this can actually do. So this is another layering effect that you can do alongside the CBD if the CBD alone is not helping you get to where you need to go. This is a slide that if you have a phone, I would recommend just taking a little snapshot of. We actually have these at our Canada Kids table back here in the back if you want a hard copy. This shows you the 4 different compounds at the top that we have medicines for, which are the most common medicines in the market. CBD, CBDA, which is also an acid just like the THCA, THC, and THCA. And as you go down the list, you'll see which of these different compounds we have found therapeutic value in when working with our patients on an anecdotal basis. Has everyone had a chance to grab that? I can move on. So I wanted to show you this slide because these are 2 patients that we work with currently. And what I want you to notice is that both of these patients have tonic-clonic seizures, okay? But what you're gonna see as we read through these is that their dosing is very, very different. Male or female that's not what changes it. It's the individual and how they are genetically hardwired. This male patient had daily seizures, horrific seizures, dozens of them a day, to the point where he had some neurological deficiencies. He has now been over 3 months seizure-free, which is the first time this has ever happened since he started having seizures as a young child. and he's on 150 milligrams per milliliter of CBD a day. That's 150 milligrams of total active CBD. We've been splitting those into 2 doses. So in the morning he gets 75 milligrams, and at noon he gets 75 milligrams, and that has been all he has needed to get him through the day. Now this has again been one of those situations that's been trial and error, as most of these cases are. But we have now found this guy's sweet spot, and he is loving life. He just completed a triathlon. He rides in a bicycle behind another gentleman in a car, and he's now completing these athletic events, and he's having a wonderful, happy life. This is a female patient. She was, again, having a lot of tonic-clonic seizures and seizing throughout the day, to the point where she was not able to have a normal life either. She started as a child, and as she got older and older and older, they just didn't get better. And she's gone through every medicine under the sun with no alleviation of symptoms. She started at 100 milligrams, or we worked her up to 100 milligrams per milliliter of CBD and split it into 2 doses a day. But we layered with 25 milligrams per milliliter of THCA, and we split that into 2 doses per day. She has now been over 6 months seizure-free, and she's weaned off of her medications. I think she's almost completely off of every single one of them. And she luckily has not had a lot of neurological damage from this, and I know that's something that's very common. She's now living a seizure-free life, to the point where she feels that her and her husband might actually be able to try for a child. They're going to wait a little bit longer to see how the progress evolves, but they're very excited to think that one day they might actually be able to be parents. And we're seeing the same type of eradication, and I don't want to say complete eradication, because to say somebody's going to be seizure-free for the rest of their life, you just can't predict that with any disease. There are what we call honeymoon phases that can happen. The honeymoon phase, Jessica, when you say 3 to 6 months is usually the honeymoon phase area? Yeah. Honeymoon phases can vary as well. And what a honeymoon phase is where we see seizures completely go away, or at least be minimized on an extreme level, but then all of a sudden, for no reason whatsoever, they start acting up again. And we don't know why. And again, this is why we so desperately need the research, and we're so excited to see companies out there getting on board with this, filing INDs for an investigational new drug, and pushing these through the hospital systems, and battling with the DEA in order to get licenses to do these actual trials, so that we can start mapping the brain and understanding the genomics of a patient, and really drilling down to more of a personalized medicine. And that's what's going to take me into my next section of my talk, is really personalized medicine. Because what's happening with so many of these different indications and so many of these patients is that we're just giving them a blanket protocol. If you walk in and you're diagnosed with a specific kind of seizure, then it's this medicine first, or that medicine second, or this medicine third. And what we are individuals. We are all unique on the inside. We all have different mutations, our DNA is different, and we need to be treated as such. And that's really been our goal with Canakids and CK Sciences, which is my research arm, to start pushing forward genomics and looking at these patients from the inside out versus the outside as a blanket.
In many instances, as you just say, I'm tired of this, I don't want to do it. If you're on a study drug, you may have to be told that you can't stop it suddenly. Yes, you can get out of the study, you can stop being a volunteer, but you're going to have to take 8 weeks to come off the drug, and we're going to have to check your blood anyway. But you have to have that explicitly told to you. And all of that is in your rights statement, and in California you sign a separate form for your rights first. That's not true at every place. The consent forms tend to be, for most sponsored clinical trials, 10 to 15 pages long. Does anybody read every line? No. No. You do.
No, you don't.
They don't. They don't, because the front part of it usually tells you exactly what's really going to happen, and then the next part tells you what the risks are, and the rest of it is boilerplate. The hospital's not responsible if you trip on the stairs coming to clinic, but they are the sponsor will pay if you get liver failure from the drug. So all of those things are in it, and they're in it line by line and explicitly, and they really should be read. And then there's always in a consent form who to call if things are not going well or you feel your rights have been violated. Now, every institution has to put every study through something called an IRB, Institutional Review Board. In academic institutions, it's almost always an in-house, their own IRB. In private practices, they can use a central IRB, which is sometimes somewhat of a conflict because usually the sponsor is paying that IRB to approve. There's also ways that clinical research, I mean, if you look in the LA Times, every week there's ads for, do you have this? Call Clinical Research Associates. There's private companies who are doing a lot of clinical research. They are not the same because they're not doing the rest of your treatment. They are only doing that trial. So you could be in a trial with your own doctor, if they have one there, where all of your medical care kind of gets folded together. You'll know which parts are trial and which parts are your own, are your regular care, but it's all together. It's like united. You could be in one that's with a different doctor. So I have kids who are on my site on one clinical trial, but their regular neurologist is at one of the other centers in LA. I send them letters back and forth, whether they read them or not, I don't know. They have to be told that they're primary patients on the trial. You have to be willing to tell your doctor you're on the trial. It's most of the time to get on with it. I have not really had anybody who's on a trial where we have no other association with them, but the private CROs do. You come in, you're on a drug trial, you're off the drug trial. They don't take the next step with you. You go back to where you came from. And that's a somewhat different situation. So that's some of the basics I wanted people to understand. I want you to understand that it is not the same as regular medical care.
Okay, so that's essentially what we've discussed. Now, another thing. Does anyone have any questions about that?
So, go ahead. What is in the future?
Oh, that's great. I wish I could see the future.
No, but I mean, is there things that you're working on now that would be like cutting edge, like things that you're looking at, or
like how successful is the RNS at this point here on the West Coast?
Thank you.
That's what you want to know.
The RNS.
Yes. How many do you do?
Sure. So RNS is a fantastic tool. It's a very specific tool. So RNS is not right for everybody. In fact, RNS is amazing in that it fills a gap in a place where we didn't have an intervention before. So for example, if we found that area of the brain that we think is causing seizures, so let's say we were in this camp, we found the area of the brain, now we want to do an intervention. However, we don't feel like a resection or an ablation, a classic intervention, we don't feel that is safe because it might actually cause a problem, it might cause a deficit. A lot of times, it is safe and we know that we can proceed with an intervention, but sometimes it's not. For example, if there's two areas of the brain that we're looking at that are causing the seizures, and resecting both of them doesn't make any sense, right? Especially when it's both temporal lobes, probably the most common situation. Or if the area of seizure onsets is in speech areas, where we don't want to risk any sort of speech problem or deficit from that. So in that very unique situation where we have found the area of brain we want to intervene in, but we cannot intervene because it's too dangerous, that is the person where RNS fills a gap we never could fill before. In the past, we told those patients, we're really sorry, there's nothing we could offer you, it's not safe. And there's not much we could do. There were some surgeries that we kind of were created for this purpose that were never quite very satisfying as far as their results, and often we didn't even offer them. But this is kind of a revolution in the sense that it fills a gap that we couldn't fill before. Now, it's not right for everybody. In fact,
this is a very specific person that it's right for. But for that person, it can be wonderful. It can be wonderful. And I think, you know, looking at global statistics of RNS, you know, RNS is 60%, you know, after 5 years, or 70%. That's really hard to say because everyone's going to be a little bit different. So what if they didn't find the focus or didn't find it correctly, you know, in the patients where it didn't work on, or that it does work on? It's a very subjective kind of concept. So I think it can work very well in those scenarios. I wouldn't use it on everybody. I wouldn't use it on people who I wasn't confident in that I actually understood what was going on with the circuitry in the brain. So I hope that answers your question.
So are you also involved in like the VNS, like also like the ones that are not in the brain, but the ones here too? Are you also the surgeon for that too, or are you only?
I do both. I do both. So I do vagal nerve stimulators. The nice thing about vagal nerve stimulators is that it's not a particularly risky procedure. It takes about 2 hours to do, and it's you know, especially compared to intracranial procedures, it's just the risk profile is a little bit more favorable. Now,
but you still do the workup just the same?
Not quite. Not quite. That's not usually my call. If it were up to me, or in my patients, let's say, if I think someone is eligible for a surgical workup, if I think they're the right kind of patient, then I absolutely will push them towards a surgical workup and say we always have VNS in our back pocket. We can always do a VNS, you know, and that could be the result of your surgical workup is that VNS is the right decision for you.
But I really find, and this has been shown out in research too, the more education they have, the more they understand their disease, the better that they kind of can deal with it and can cope with it.
Especially, I know that a lot of kids, or a lot of people who do end up succumbing to SUDEP do so around their early 20s when they go to college, they don't take their medication, they don't feel they have to. So I'm already gearing up my kid and saying, hey buddy, this is what SUDEP is. These are the statistics. No, you don't have grand mal seizures and you're controlled, so your chances are not likely. But this is what happens if you stop taking your medication, if you think it's smart to start smoking or drinking. So I'm kind of, and I say that probably once a month. I hope it's not adding to his anxiety, but he pretty much goes, oh, okay, he's very logical, and he's like, all right, and he likes the information.
That's exactly.
Yeah.
But the problem is, you know, when they're going to college, they're 17, 18, whatever, they're going to do what every 17 and 18-year-old is going to do. So, yes, they have this additional thing on top, and it does really affect your life. I mean, my wife talks about having seizures when she was at NYU in New York, and like being on the subway and having a seizure, and, you know, being terrified about, you know, things like that. But, you know, they do it, and I've got 2 patients that just started college, and both of them have called me back and like, oh, I'm having this. I'm like, well, you know, nicely, I'm like, oh, you know, I've heard that people like stay up all night and, you know, maybe have a drink or 2, you know, and then I got back, well, maybe one, you know, so if they say maybe once, that's a dozen times, you know, so it's, you know, a lot of education, a lot of kind of reinforcement that, you know, and yeah, you know, the other thing is telling people, which I've seen people do, is that you can't drink. You have epilepsy, you can't drink. You can never do anything like that. So there are specific types of epilepsy that you're really increased risk, but I mean, we all have to be reasonable and logical. And are they more likely to not drink if you say you cannot absolutely drink? Or if, you know what, if you're there and yet you have a beer with everybody else so you kind of help fit in, that's fine, you know? But just stop. And then, like, you know, keep it in reason, keep it within reason.
This is what could happen.
Right.
If blah, blah, blah. You know, I can't be there with you all the time, so, you know.
Right.
Choices that you make will affect, you know, how you want to live life.
And unfortunately, sometimes they have to experience it themselves to really understand. I've seen that too. You know, they called me, they had a seizure. I'm like, okay, well, you know, you're not sleeping, you're sick. Well, I may have missed a couple doses of medication. Like, okay, you know, but you have to have a good rapport with the patients, because if you don't, they're not going to tell you. And then you have the whole other addition of driving. And the kids who are driving, you know, they have one seizure, they can't drive, they don't want to tell you, you know, that they had the seizure. So it's tough. it's a really tough age, but I think with more education and things like that, we can make a big difference.
What else? Haley Hopes and CW. Hey, that's really the only two, right? The age out. Yeah.
Right.
Yeah. No.
Yeah, we were talking about that a little bit before. It's really difficult, and the key, the difficult thing is finding adult people who are comfortable seeing that type of patient. I mean, there are specific patients that I know that, and I've sent to my own adult people at UCLA. There are other patients that UCLA might not be happy with me saying this, but I know that Christy Heck over at USC, she's a good person for that patient, and so I've sent them to her. So one of our goals is to find this, to come up with a network in the greater Los Angeles area of neurologists and epileptologists who feel comfortable taking care of. One may say, okay, I'll do like JME or focal seizures, but I'm not doing out-of-office surgeries. So our goal is to really find that network, and the whole idea of this adolescent center is to really expose all of this, get all this started treated, and so to make the adult practitioners feel more comfortable taking patients.
It all depends on what type of anxiety is. As you know, anxiety could be many different kinds. It could be like episodic or associated to a specific trauma, or is it like a lingering thing every day? So depending, there's so many different disorders that are under the umbrella, so I'm not sure which kind you're talking about. Okay. I don't really, yeah. I normally see it that they tend to have it either surrounding, like within a year of the epilepsy, or they had it prior to the epilepsy. But like I said, there is still a relationship, a bi-directional relationship, that epilepsy tends to, people that have epilepsy tend to have higher chances, like 2 times as high chances of having anxiety or any other. Cognitive behavioral therapy, it could work for epileptic and non-epileptic seizures, and with anxiety. It has to be modified and changed depending on what disorder you wanted to treat. So, got it. Thank you. Sure, no problem. Any other questions? Yes.
But also some of the medications can cause anxiety themselves.
Yes, we talked about it earlier. We talked about these medications causing the anxiety or mood state problems, for that matter. So Keppra, Sonogram, Topamax tend to have mood. Omphie is one of the benzodiazepines. So it's a different type of benzodiazepine. And normally the benzodiazepines tend not to cause anxiety, but actually when you stop them, that cause the withdrawal symptom that tend to occur. Sometimes it's paroxysmal. Some patients that get Ativan get really anxious, and that's very odd, but like I said, we call it paroxysmal side effect. It normally calms people, and it's more of a sedating than actually causing, the upward anxiety-related things. So they could potentially do, but we'll see. Yeah.
Frustration.
Yes, definitely. Any other questions or concerns? No. Go ahead, take a spin.
Think about autism spectrum disorder, okay? When we think about this, so social communication deficits and restrictive and repetitive behaviors. So if you have this and this, you meet a clinical diagnosis of autism spectrum disorder, okay? Based off of something we call the DSM-5, our diagnostic manual where we diagnose these other what we call mental health conditions, okay? So this is based off of the DSM-5, all right? So now going back to, we talked a little bit about what epilepsy is, which a lot of people know here, okay, and what the relationship sort of is here. So within autism, if you meet these two criteria, you have that diagnosis, but then there are a lot of other, what we call comorbidities, okay, or things that can fall in line with autism as well that many of these children face. One of those things is epilepsy. We also talk about ADHD, we talk about anxiety,
We talk about depression and irritability. Okay? So after we make this diagnosis, a big part of this is not only getting intervention for these things, but monitoring for these things. Okay? Now let's talk a little bit about how epilepsy and these two overlap. Okay. For the general population, the risk of developing epilepsy, we used to say was about 1 to 2. When you take the whole world, probably about 3 to 5%, okay? In children with autism, that risk goes up to 30%. Okay. So much higher risk when you're talking about a child with autism spectrum disorder. Now, why is that the case? Or how do these sort of overlap? Now, a sort of, I don't want to say basic, but kind of scientific, but kind of bringing down the scientific explanation of that, is one of the reasons we think a seizure happens or epilepsy happens is because there's an imbalance of inhibition in your brain and excitation in your brain, right? So your brain gets overly excited, these brain waves, and there's not enough inhibitory input, what we call given by GABA, okay, which is inhibitory, in order to quell that down so that you don't have a seizure, okay? Now that is a genetic underlying thought, and it's thought those same genetic abnormalities also exist in autism spectrum disorder, okay? Lack of GABA or lack of this inhibition that genetically could also lead to having autism spectrum disorder. Now the other thought though is maybe a child is predisposed to having epilepsy. Some of the ways those brain cells are firing are a little abnormal. And when they're firing abnormally that early, it's affecting your brain or the way your brain develops. And before you even develop a seizure, you might manifest into having autism spectrum disorder, okay? So there's a lot of research and a lot of study going into how are those two things related. And that's primarily looking at different genetic disorders, okay? So I'll name a couple of those genetic disorders. One is Down syndrome, which you might be a little bit more familiar with. Higher risk of epilepsy, higher risk of intellectual disability, higher risk of autism spectrum disorder. Another one is tuberous sclerosis complex. You guys might have heard it's a genetic condition, very high risk of developmental delays, and epilepsy, okay? As we're better understanding the genetics of epilepsy and the genetics of autism, we're starting to see that there's quite a bit of overlap there, all right? And that's where a lot of the studies are going to be targeted, okay? And then just stop me as you guys might have questions in between. Just giving you guys a little bit of background though. All right? So when a child comes into my clinic either with autism or epilepsy, I'm very much screening for a lot of other things. I'm not just treating the seizures. I'm not just treating these other things. I'm not just treating these core deficits. I'm monitoring to see if they're at risk for epilepsy or seizures. And if they are, making sure we get the right treatments. And I'm monitoring if they have epilepsy, how they're doing cognitively and how they're doing behaviorally, right? So before I kind of go on to the next sort of steps of epilepsy and autism or things like that, we'll talk a little bit of just about epilepsy, okay? So let's say your child or an individual has a diagnosis of epilepsy. If their seizures are uncontrolled or difficult to control, we worry that affects their development, right? Or their ability to learn, okay? It can also affect their language, right? It can affect the way they interact with other people. So then we start thinking about what make up the diagnosis of autism spectrum disorder, right? Social communication difficulties and repetitive behaviors. So some of our patients with epilepsy who have pretty hard to control seizures might have social communication difficulties, might have repetitive behaviors, and now they meet this clinical criteria, right? And it's our job to sort of parse that out, to start saying, okay, your diagnosis is autism spectrum disorder, but how is that maybe different from another child without epilepsy, okay, that has autism spectrum disorder? Or how may we treat you a little bit differently, okay? Does it make sense so far? Okay. So let's talk now a little bit more of epilepsy in the context of autism, okay? So we now know through both genetic studies and just clinical studies of patients that kids with autism are at a higher risk for epilepsy, like I said, up to 30%. And as more and more studies have been done, we know a little bit more about why that might be, with the GABA, the inhibition, the excitation. But now, who's at higher risk for developing epilepsy in this cohort, okay? So there have been a couple of big studies. One study looking at a large database of patients who came in with autism primarily, and then they looked at who developed epilepsy, and then another large study that kind of binned these patients together based off of different characteristics. Their intellectual ability, okay, their autism severity, meaning how severe are they in these areas, their gender, their gross motor function, okay, and whether or not they'd had a history of other medical problems. And what we found are kids who have more intellectual difficulty, who have more severe autism severity, females, which we'll talk a little bit more about, so female gender, and more difficult or more affected motor development are the ones who are much higher risk of epilepsy, okay? And that's thought to be kind of tying back in. And I know I'm getting a little scientific, but also keeping it basic so I can explain both of those things. The reason that's thought to be is that kids who have a lot of those other more severe autism, more severe motor function, more likely to have a genetic etiology that might be causing the two, okay? Similarly with girls, the thought is with girls who have two X chromosomes, thought is that maybe they're more susceptible for these genetic abnormalities causing epilepsy. So what does that mean clinically, right? If I have a child who comes in with epilepsy and autism, who is a female, who has more severe autism symptoms, more difficulty in school, I'm going to monitor a lot more closely, right, to make sure that we're not worried about the development of seizures, okay?
Mitochondrial, cerebral fluid issues. Mitochondrial dysfunction is super common in kids with autism and epilepsy. It's probably the most common comorbid feature. And there's a standard best practice treatment protocol to follow for that. It's a mito cocktail, which is mostly supplements. And literally, you can improve the cell function. The mitochondria is how cells communicate back and forth. And almost all kids with seizures have mitochondrial issues on top of it. So generally speaking, you have multiple comorbidities, and that's one of them. So, and that's in that book. Okay. Yeah.
Thank you very much.
You're very welcome. And why are we on camera?
I don't know.
And did your surgeon tell you that you're having an epilepsy operation or you're having a tumor removed?
Well, at the time it was a tumor removal, and it did, I mean, she was having 8+ big seizures a day previous, and then she went to 0, and she was completely seizure-free for 2 years. And then she had 3 breakthrough seizures, and then she would wake up with headaches until she was having seizures in her sleep, which was shown on EEGs. But she doesn't have any more seizures during the day. But so that's, and we have been doing the ketogenic diet on our own with the dietitian, but not the official ketogenic diet. And she's been feeling much better, but now since the tumor's growing back, we want to.
I'd like to see that scan. I think your daughter has a type of epilepsy that can be cured with an operation. So
yeah, we're getting the second treatment at UCSF.
Yeah.
And they want the one that may work up.
Yeah. So let me show. So. So it's the temporal lobe, right, of the brain on the side. This is the tumor, okay? So one approach, so if your surgeon is not an epilepsy surgeon, one approach is to go and just remove the tumor, okay? That doesn't work very well at stopping the epilepsy because when it, if you're having a surgery done purely for tumor purposes, that works well. Go in, remove it, see what it is, what cells they are. Usually the tumors that present in childhood are very commonly associated with epilepsy, and it's not just the tumor, it's the area surrounding the tumor that can actually be, so.
And they are seeing that in the EEG that it's coming from right
Exactly. So it's very important as you get a workup to see, and that's why this surgery, quite often when we do it at UCLA, we do recordings of we do an EEG directly from the brain during surgery, because when you're in surgery, you're not going to necessarily see all the abnormality. It's subtle. It's actually invisible to the human eye. So what we do use is a lot of the technology we have to pinpoint where that abnormal area is. And usually with tumors, that especially with the seizures continue, they break through and they come back, it's usually the surrounding area around the tumor that needs to.
She did have a small piece left in her hippocampus. It was a 7 millimeter piece that they didn't want to dig into too much at the time. And so we knew that was staying there, and that stayed static, but now it's still coming back.
I suspect, and then nowadays, so with that, depending on what it looks like, we may be able to put a laser fiber in there. Yeah, that's a great option, especially for kids that have had surgery, where you can avoid the big scar and big incision again. So you can just put this is where we put a wire, small catheter. Let's say we have a small spot here that we want to treat. Instead of doing a big operation where you have a large scar on the side of your head and you go in, you can do a tiny stab incision, a few millimeters, make a very tiny hole in the skull, and pass a laser catheter directly into the spot, and you destroy that tissue from the inside out, and kids recover beautifully.
It's like you're short-circuiting very quickly, okay? And then you're done. But in electrographic status epilepticus of slow wave sleep, the pattern in sleep, as you enter into sleep, not REM sleep, but the other stage of sleep, is that you start spiking, and you do it almost continuously. Almost every second of the page has spikes, typically. The guideline is that there's, in a 5-minute segment of EEG, you're looking at 85% of the seconds have spikes in it. And then it has sort of a rhythmicity. That if you looked at it like a metronome, you could almost play music to it, because it kind of looks rhythmic there. That is the EEG pattern, but that's actually, the EEG pattern isn't actually ESES. The EEG pattern actually has a different name, continuous spike wave of slow wave of sleep. ESES is actually a clinical phenomenon where you have that EEG pattern, but you also tend to have a decline in some of your cognitive capabilities or motor capabilities. The original way that I think it was best described was in what's called the Landau-Kleffner syndrome, which is also called the acquired epileptic aphasia. The Landau-Kleffner syndrome, described by Drs. Landau and Kleffner, is typically in a child who has relatively normal development but may already have some speech delay problems. And then, as they're going, they start to regress and almost appear autistic and lose all of their speech. And not just their speech changes, but their interaction with the world changes. And this was the classical way that it was described. These kids can have seizures, absolutely, but they can also have relatively few seizures. They don't have to have lots of them. And when you put them on EEG, you may find while they're awake that there's spikes, but really once they fall asleep, it just is continuous throughout there. And they typically look like they're over the whole page, but they don't have to. So that's the typical description of the Landau-Kleffner syndrome of ESES, an acquired epileptic aphasia. But you can have a more focal area where instead of it looking like it's the whole brain, it's really just, say, the right side over the motor area. And that kid might have, instead, a left-sided progressive weakness that can occur. Or there have been kids who've had visual spatial difficulties because of their focal ESES. Or there have been some cases where you don't actually use that spike wave index of 85%. And what it ends up being is that these criteria are very helpful for us to make a diagnosis, but you have to be very careful about making sure that when you're using the criterion on EEG, you're not forgetting the criterion of what's going on with the patient. Maybe this patient's spike wave index is only 70%, but they started with a speech delay already, and as you started seeing the changes on the EEG, they had that language development. Am I not going to give the child that language regression? Am I not going to give the child the appropriate treatment and diagnosis just because we didn't hit the 85% threshold? No. I'm going to say that you fit that clinical picture. And that's important because a lot of the research that's been done and that is out there disagrees about what spike index you should use. And some will go down as low as 50%, some will go down as high as the 85%. But really we need to remember that we're always trying to treat the patient.